So today topic is ectopic pregnancy and miscarriage diagnosis and initial management. So I took my lecture from the NICE guideline, and after that I will share one presentation which is unfortunately I try to make by myself but I didn't. So I take a presentation from other fellow, and in return I can just publicize their group that they are the one making very good preparation for MRCUG2, because I don't have any another presentation for green top guideline. So incidence of ectopic pregnancy: approximately 20% of pregnancies miscarry, and miscarriages can cause considerable distress. So, early pregnancy loss account for over 50,000 admissions in the UK annually, and the rate of ectopic pregnancy is 11 per thousand pregnancy. You can make it 1 per thousand, 1%, because 11 per thousand mean 1 per 100, or with the maternal mortality of 0.2 per thousand estimated ectopic pregnancy. So this is a very important incidence, that mortality rate due to ectopic pregnancy is 0.2 per thousand. About two-thirds of these deaths are associated with substandard care. So misdiagnosis of ectopic pregnancy, it is actually it need a incident reporting, and the clinical governance. Actually, it is one of the those issue adverse event that you miss the diagnosis of ectopic pregnancy. So it is a very serious event. So 1, 2, and 3, early pregnancy assessment service. Um, in the NICE guideline, they use three terminology, where the patient with actually they use the word woman, not patient, not pregnant woman. They just use the word in this guideline woman. So they have to see in uh, mm, three areas where they are going to be seen by healthcare personnel. Ideally, it should be a dedicated service provided by healthcare professional competent to diagnose and care for women with pain and or bleeding in early pregnancy, and offer ultrasound and assessment of beta HCG level, and be staffed by the healthcare professional with training in sensitive communication and breaking bad news. So it should be ideally at the services who can provide and diagnose pain or bleeding in early pregnancy. Either it is a threatened miscarriage, or it is an abortion, or it is an ectopic pregnancy, molar pregnancy, or they have the facilities of ultrasound and beta HCG, and also they should also deal with the sensitive communication and the bad news. Early pregnancy assessment service. Early pregnancy assessment services should accept the self-referrals from women who have had recurrent miscarriages or a previous ectopic or molar pregnancy. In your books, you will find the EMQs, that the patient have molar pregnancy, or patient have recurrent miscarriages, or patient have a history of previous ectopic pregnancy. Now she has pain and bleeding. So in the EMQ, you can find this option of self-refer to early pregnancy assessment. These women, they don't need GP, or they don't need community care, or they don't need anyone to refer them. They can just present themselves early pregnancy assessment unit and tell them they have the bad history. So these women, they should be accepted without any referral. Okay. So all other women with pain and bleeding should be assessed by the healthcare professional, such as GP, accident and emergency doctor, midwife, or nurse before referral to an early pregnancy assessment service. For example, other women who have no risk factor, they can go to the GP, they can go to emergency, accident emergency, or midwife or nurse. So they have the system, and they have to follow that system. But the women with the high risk history, directly they can go to the early pregnancy assessment unit. But other women who don't have high risk history, they have to be referred by GP, or emergency department will triage them and then refer them accordingly. Okay. If the service is not available and the clinical symptoms warrant further assessment, refer women to the nearest accessible facility that offers specialist clinical assessment and ultrasound scanning, such as gynae ward or accident and emergency service with access to specialist gynae support. Actually, when I was reading the presentations of other candidates, like who are teaching other mentors, sorry, majority of them, they are missing this part, that which specialty or which area they have to refer the woman, because these type of questions also coming in the exam, because this is showing their risk system or referral system, that what type of woman will be referred by which category. So this is very important to understand their system, that only with high risk women can go in the early pregnancy assessment unit and then refer themselves, but the other women, they have to follow the path. Okay. And if because these services may be not available in that area, or it's maybe not available 24 hours, then women will be referred accordingly to the nearest possible facility which have the ultrasound facility or a specialist clinical assessment. For example, gynae ward or accident and emergency services, they can call the gynae department, like all ER departments, the ER doctor is calling the relative specialties. Symptoms and sign of ectopic pregnancy and initial assessment. Refer women who are hemodynamically unstable, or in women there is a significant concern about the degree of pain leading directly to accident emergency. For example, if patient is hemodynamically unstable, the GP or nurse or midwife, she will definitely refer this patient directly to emergency. So emergency department, then the gynae specialist unit will come and assess the patient. Okay, so this is the only thing where patient should be directly referred to the emergency. Be aware that atypical presentation for ectopic pregnancies are common. So in the recalls question, I was seeing they were giving this scenarios that the patient have right iliac fossa pain, pregnancy test is positive, or patient has diarrhea, or patient has urinary tract infection. So urinary tract infection symptoms. So you have to know that maybe they want you to take diagnosis of ectopic pregnancy. So be aware that ectopic pregnancy can present with a variety of symptoms. Even if a symptom is less common, it may still be significant. Common symptoms, they are common symptoms, and they are uncommon symptoms. The common symptoms are abdominal or pelvic pain, amenorrhea or missed period, vaginal bleeding with or without clots. Even if they will give you the scenario, the patient came with heavy bleeding, still you have to think about ectopic pregnancy, because it's written that vaginal bleeding with clots. So can be. Okay. So other reported symptoms are breast tenderness, GIT symptoms, dizziness, fainting, syncope, shoulder tip pain, because there are refer pain because of peritoneal irritation, and urinary symptoms, passage of tissue and so maybe in the scenario, they will give you vaginal clots. Patient is passing vaginal clot with history of passage of tissue. So still you think about of ectopic plus complete abortion or incomplete abortion, or pregnancy of unknown origin. So just don't distract yourself with the symptoms, because atypical symptoms can be present with this ectopic pregnancy diagnosis. Okay, rectal pressure or pain on defecation. This is not endometriosis, and this is again ectopic pregnancy. Now we discussed the symptoms. Now there are signs. Okay, be aware that ectopic pregnancy can present with a variety of signs on examination by a healthcare professional. More common sign is pelvic tenderness, adnexal tenderness, abdominal tenderness. Okay. Other signs are cervical motion tenderness. These are also being reported. Rebound tenderness or peritoneal signs, or pallor or abdominal distension cause of collection of blood. Enlarged uterus, tachycardia more than 100 beats per minute, or hypotension less than 100 by 60 unit of blood pressure. Shock or collapse or orthostatic hypotension. These are the signs. Okay, clinically, you can see all these signs in the patient who is hemodynamically stable or unstable. So, symptoms and sign of ectopic pregnancy initial assessment. During clinical examination of any woman of reproductive age, think first of pregnancy and then offer the pregnancy test, even if they have non-specific symptoms. This is the rule. This is the rule. Any patient in the ER presenting with any complaint which might be related to early pregnancy complication, you have to offer them pregnancy test. Okay. The symptoms and sign of ectopic pregnancy can resemble the common symptoms and sign of other condition, GIT and urinary tract infection. So all healthcare professional who are involving in the care of women of reproductive age should have access to the pregnancy test. So First we have to do any patient. Now they have said any patient refer immediately to early pregnancy assessment service, or if it is out of our services, you have to refer the patient the gynae services for further assessment of women with a positive pregnancy test. And okay, now actually there is a very in the NICE guideline. When you read the NICE guideline, I will give you at the end the summary. So there is summary on the table, okay, because it's very confusing. They said if there is a positive pregnancy test and if they have any of these symptoms, for example, positive pregnancy test with pain or abdominal tenderness, this is the one symptoms, or pelvic tenderness or cervical motion tenderness, you have to exclude the possibility of ectopic pregnancy, even in the absence of risk factor, such as any pregnant patient, if she has any symptoms, you have to rule out the ectopic pregnancy, because one third of women with an ectopic pregnancy will have no known risk factor. This is important. Recall question that one third of women with ectopic pregnancy, they don't have risk factor. Two-third maybe have risk factor, but one third they don't have any previous history of ectopic pregnancy or other risk factors. So take care. This incidence is one third. Okay. So refer to an early pregnancy assessment service or out of our gynae service. If the early pregnancy assessment service is not available, women with bleeding or other symptoms with early sign and sign of early pregnancy complication, again before they said any patient who have pregnancy test positive with pain or bleeding or abdominal or cervical tenderness, you have to think about of ectopic pregnancy. Also, any patient who is pregnant and who have bleeding with pain, or who is she's 6 weeks pregnant or more, or she's unsure of dates and she has bleeding and she has even bleeding, no pain, but she has bleeding, then you have to refer to the refer according to the clinical situation, because these are the criteria for pregnancy of unknown location. We don't know, they have pregnancy test positive, they have pain, and or they have bleeding, and we don't know where is the pregnancy is. Okay, before doing ultrasound. Symptoms and sign of ectopic pregnancy and initial assessment. Use expectant management for women with a pregnancy test. Now this one, please focus this one, because the questions are coming from this slides. Okay, you have to manage patient expectantly. If she is less than 6 weeks pregnant, she has bleeding but no pain. Okay, any patient, for example, any patient, she's para 2 and by date, she's the date whatever she's telling you, because you don't have always rely on LMP. For example, she's telling she's 5 weeks pregnant and she has bleeding, and you do pregnancy test, it's positive, but she don't have pain. Okay, she don't have any risk factor, low risk pregnancy. Or what you will tell them, you will tell them, okay, you have right now only bleeding, you don't have pain now, so what you have to do now, you can go home. Okay, and if your symptoms progresses, for example, if your bleeding become heavy, or if you start to have pain or other symptoms, return back. For these women, you will tick the expectant management. The pregnant woman coming in the ER less than 6 weeks with bleeding, with no pain. Okay, what you will do, you will repeat a pregnancy test after 7 to 10 days and to return if it is positive. So here I will tell you one more thing. Any pregnancy, normal pregnancy, it should end within 2 weeks. That's why I was yesterday telling the gestational trophoblastic disease, they are doing after 3 weeks pregnancy test. Why? Because the persistent trophoblastic tissue you will find even after 3 weeks of pregnancy event. Okay, but if it is complete miscarriage, or if it is, it should be negative after 2 weeks. This is the rule. The 3 weeks rule is you are doing after 3 weeks. Why? Because after 3 weeks, the pregnancy test should be negative 100%. If it is still positive after 3 weeks, that means either it is a persistent trophoblastic tissue or ectopic pregnancy. That's why we are doing after 3 weeks. But if you want to make sure, if in the exam the patient asks you when do my pregnancy test become negative, you have to explain in the counseling that after 2 weeks your pregnancy test will be negative. Okay, so here they are saying that you in this patient you will do expected management if she has only bleeding and no pain, and you have to repeat the pregnancy test after 7 days. A negative pregnancy test means that the pregnancy has miscarried. Okay, this is the latest 2019. They write like this. If a woman is referred to an early pregnancy assessment service and uh, explain the reason for the referral and what she can expect when she arrived there. Anyhow, you have to explain the patient before sending her back to the home. I think this is clear that this woman should have expected management, only pregnant with bleeding, no pain, less than 6 weeks. Okay, diagnosis of viable intrauterine pregnancy and of tubal ectopic pregnancy. How will we diagnose? Offer women who attend an early pregnancy assessment service, a TVS, to identify the location of the pregnancy and whether there is a fetal pole and heartbeat. So TVS is the method of choice, and it is the best one. Okay. Before old guidelines, they are saying laparoscopy, but now TVS is the gold standard. Okay. Consider a transabdominal scan for women with an enlarged uterus, other pelvic pathologies such as fibroid and ovarian cyst. So you can offer these women the fibroid or ovarian cyst if any pelvic pathology offer them. Consider. But if TBS is unacceptable to women, offer a transabdominal scan and explain the limitation of this method. Okay. Okay, I want to, sorry. Okay, you can start from down one and then we will go up. Okay, first of all, what we have to tell that diagnosis of miscarriage, you cannot be guaranteed if you have 100%, if you have ultrasound, and you cannot say that 100% accurate, and still there is a small chance that misdiagnosis can occur, especially if the patient have very early gestational ages. So you have to tell the patient that one ultrasound, we cannot exclude or we cannot diagnose anything usually. Okay, so when we are doing ultrasound, first of all we want to know whether it is an intrauterine pregnancy or no. Okay, so we have to look for the fetal heartbeat. After that we find the gestational sac and the fetal pole. We have to look for the fetal heartbeat. If there is no heartbeat, then there is a fetal pole. Okay, if there is a fetal pole, we will measure the crown rump length, only measure the mean gestational sac diameter if fetal pole is not visible. So step by step, first of all, we want to see whether it is intrauterine or extrauterine. Okay, if there is an intrauterine, then we will see the fetal pole. And if we will see the fetal pole, we want to see the fetal heartbeat. If there is a fetal heartbeat, it's okay. If there is a no fetal heartbeat, then we will see the fetal pole. If there is a fetal pole, okay, then we will measure the crown rump length. And until crown rump length is 84 mm, we will measure the crown rump length. After 84 mm, we will measure the, if the baby, this crown rump length is more than 84 mm, then we will measure the head circumference. Otherwise, less than 84 mm, we will measure the crown rump length. So if there is no fetal pole also, then at the end you will measure the gestational sac. Okay, now in this slide I remember I have in my personal exam I have 2 recalls. I will tell you which recall in the exam, and you will be surprised how they are giving the exam question. Okay, so if there is a fetal pole, you will measure the fetal pole, and if there is a no fetal pole, then at last you will measure the gestational sac. Otherwise, routine, you are not measuring the parameters of gestational sac, which is actually in the 2 diameter, anterior, posterior, and transverse diameter. If the crown rump length is less than 7 mm with a TVS and there is no visible heartbeat, then you have to do ultrasound after 1 week before making the diagnosis, and further scan will be made according to the need. So if there is a no fetal heartbeat, TVS, you will repeat after 1 week if it is less than 7 mm. If crown rump length is more than 7 mm, okay, and there is no heartbeat, then what you will do? You have 2 options now. The baby crown rump length is, for example, they will give you in the exam, maybe it is 7.5 mm, okay, and there is no heartbeat and it is TVS and patient is sure of dates, what you will do? Either you will take a second opinion, you will take the second opinion of your senior or second doctor and diagnosed, okay, and or you will perform a second scan again after 1 week before making a diagnosis. So if it is less than 7 mm, 100% you will call her after 1 week. But if it is more than 7 mm, here now the confusion will come in the exam, because more than 7 mm mean how much? Maybe it is actually in the exam they're asking the fetal pole is 8 mm. So now everybody is so confused because 8 mm is way larger than 7 mm. And now what you will select? You will select after 1 week. And actually there was no option of to take the second opinion. There was written that in the choices, it was written that conservative management, expectant management, medical treatment, surgical treatment, or I don't think so, repeat the scan, or maybe there is option of repeat the scan, maybe or may not be. But sometime they are giving you in the scenario, and by giving any 8.5 or 8 more than any way larger than 7, that mean it is a confirmed diagnosis, you don't need second opinion. Okay, why, what happened? My meeting will end in 10 minutes. Why? I don't know why. Okay. Sorry, today is the last day of the payment, so maybe I will share again the link if it is come to end, okay? Because after that it cannot be recorded, because I don't know, it will be renewed by itself, because today was the last day of payment, okay? Okay. So if there is no visible heartbeat when the crown lump length is measured using a transabdominal scan, what you will do, you will record the size of crown lump length, and you will do the repeat ultrasound after 2 weeks. This one, abdominal scan, there is no confusion. They didn't give any dead mark that 7 or more than 7. They just tell if you will do abdominally, just call her after 2 weeks. Full stop. Only problem coming is TVS and less than 7 and more than 7, and there is no limit of more than 7. But in the exam, maybe they will give you 8 or 8.5. So assuming that you don't, there is no option of second opinion, and you have to take the diagnosis of miscarriage. Okay. Perform a second scan. Okay, the mean gestational diameter is less than 25 millimeter in the TVS, and there will be no visible fetal pole. Perform a second scan of 7 days after the first, before making diagnosis, and further scan may be needed. Okay, so they are saying if you don't, you do ultrasound, you didn't find the fetal pole, and now in this case you will measure the gestational sac. If it is less than 25, then you will do the repeat scan after 1 week. Okay, there is no second opinion, just repeat the scan after 1 week. In my exam they give me the picture, okay, and they make one big large gestational sac, and in the ultrasound picture, that on the side it was written the gestational sac diameter is 30 mm. Okay, and I can see the small fetal pole inside, and there is no fetal cardiac activity. And or I don't remember there was fetal pole or there was, or no, actually I forget. I think there is, it was empty sac, there is no fetal pole inside, and the sac size is 30 mm. And again they're asking what you will do, expectant management, miscarriage, or you will do surgical or medical management. So sometimes they are giving you way more than the size of the one they are giving the guideline. They give you 30 mm. That means 30 mm is, and there is no fetal pole inside. That means they are giving you the confirmed diagnosis of miscarriage by giving the larger parameters. Okay, so take care in the exam, please. Open your mind, use common sense. If they are giving more the large parameters in which the diagnosis should be there, should be 100% miscarriage, don't confuse yourself with this one. Okay, until now, if anything you understand, just ask me, because I think I have to send the link again. Anything not clear, please ask me again, because this slide is very important. Anything I will repeat, please ask me.
Ma'am, please elaborate when if the sac size, sorry,
one by one, one by
length is 8. Then what to do?
Actually, in the exam, they
doctor?
yes, if they didn't give you the second opinion option, okay, if they didn't give you the second option, and in the scenario, it looks like it is a confirmed diagnosis, because 8 means the other parameters, they will give you other parameters also. So they will give you in the scenario that it's yani, it's a common sense that it is a, you don't need a second opinion. If there is in the option there is a second opinion, you tick the second opinion. Okay, if there is no option and the parameter is very much far away from 7, or gestational sac is far away from 25, it is 30, it's 32, I think maybe 30 or 32. But so you just click that one, because it's a very big sac and it should be some fetal pole, at least something should be inside now. And in that picture there is nothing, it was blighted ovum. So just keep in your mind differential diagnosis also. And if they will not give you the repeat scan after 1 week, or second opinion, or just go with your common sense and use and take it as a confirmed diagnosis. Okay, this is coming two questions with me in my exam. Okay, so I'm just telling you, in the exam sometimes they are manipulating the things like that. Okay, so don't confuse. If it is 7.2, 7.4, 7.5, okay, and still you still want to repeat the TVS scan after 1 week. But if it's still 8 they have already given you crown rump length is 8 okay, is fetal cardiac activity should be should be visible on 6 of crown rump length. And if in the scenario they are giving you patient is sure of dates, and it is, yeah, her date was corresponding to her LMP or by a scan or whatever it is, they must give you some regular cycle. Maybe they will tell you she has regular cycle or some clue that she has regular cycle or regular dates. Then go with the miscarriage diagnosis if it is gross difference between the cutoff points. Okay. Using ultrasound scan for diagnosis of viable intrauterine pregnancy. Okay, so viable intrauterine pregnancy, do not use gestational age from the last menstrual period alone to determine whether a fetal heartbeat should be visible. Alone mean that also you have to take the history, whether she has regular cycle, she was taking the contraception or no, or you have to take the history also. Only just last menstrual period will not help you that the fetal cardiac activity for this patient should be visible or no. Inform women the date of their last menstrual period may not give an accurate representation of gestation because of variability in the menstrual cycle. And you have to explain the patient what to expect in the next scan when they are waiting. Because and if you will tell them then we have to wait for 1 week and 2 weeks, it will not have a detrimental effect on the outcome of the pregnancy. Because I was seeing some recalls, they are saying the patient don't want to wait for 1 week for TVS, and she was asking because maybe it will harm her pregnancy. So you have to tell no, waiting will not harm your pregnancy, and we have to wait, and you have to tell the patient very clearly. Give women a 24-hour contact to a phone number when diagnosis complete miscarriage on ultrasound in the absence of any previous scan confirming an intrauterine pregnancy. You have always think of pregnancy of unknown location, because in our ER also many patients they are coming and they said that we have passed the baby at home, but we don't have now we need a sick leave for 2 weeks. So until you don't have any previous ultrasound in which there was intrauterine pregnancy, how you can diagnose now this is a complete miscarriage? So in these patients you do pregnancy test and you find the pregnancy test, even their history they have passed something, but you have to keep in your mind the pregnancy of unknown location. So single ultrasound without previous scan which show the intrauterine pregnancy, you cannot diagnose complete miscarriage, and you need a previous scan. Okay, so advise these women to return for follow-up beta hCG ultrasound scan until a definite diagnosis obtained. So okay, so meeting time only 2 minutes. I think I will before starting I will share the new link. Okay, I will stop here and I will share the new link, so that 2 minutes this slide will be halfway. Okay, I'm sending you the new link. Okay, I'm making the meeting end.
Okay, ma'am.